Hello guys, this is Charles Clinton, Chapter 20, Summary, Coronary Angiography and Intravascular Imaging, 11th and last edition for now for Braunwald's heart disease. Disclaimer, this is my own summary based on this great book, Braunwald's heart disease. If it helps you out, I'm glad for you. As Braunwald did his book during his residency, I'm doing these summaries for you based on his work. If it's gonna help me out, it might help you out as well. This is my disclaimer. In no way I propose to substitute what is learned in the book, and I recommend you going to the book if needed. Then this is the chapter 66, different slides, and starting off. Selective coronary angiography remains the gold standard to determine the extent of CAD. It is the only technique that can simultaneously provide both functional and anatomic information. The indications are based on the pretest probability of coronary artery disease in general. Okay, this is a great table 20.1 says current clinical practice guidelines on the indications for coronary angiography and stable CAD and STEMI and STEMI. On the left you see all what is the indications. On the right I'm trying to make this in an illustrative form type so this sinks into your brain. I hope you understand my letters. It goes from cursive to print. Okay, let's start off. I tried to make this a little more simple. Why is this green, has a green background? Since it's a class 1 indication. So it is recommended. Class 1 is the strongest indication. So starting off with stable coronary artery disease. It's for patients with stable coronary artery disease. 1. Who survived sudden cardiac arrest or ventricular arrhythmia. Remember that sudden cardiac death is usually used as a misnomer for sudden cardiac arrest, since death, if the patient dies, it shouldn't be called. If the patient doesn't die and he is rescued, he shouldn't be named sudden cardiac death. It should be sudden cardiac arrest. But whichever you use, we already understand this. Then the patient survived this event or had a ventricular arrhythmia. In the context of stable coronary artery disease, you should take this patient to the cath lab. 2. If the patient has the substrate and also now develops a heart failure symptoms. 3. If in stress testing there is a high risk features. And of course, if you think taking the patient to coronary angiography has more benefits than risks. And 4. If the ischemic symptoms, albeit optimal medical therapy, are perduring or are still present. Then if the patient is in optimal medical therapy due to the or based on the guidelines and still has ischemic symptoms, you should think on taking this patient to the cath lab if the patient is obviously a candidate for revascularization. Look at the one there, that is the strength for each recommendation. First two are B and last two are C. Okay, now in the context of acute coronary syndrome, unstable angina or NSTEMI. In these contexts, number 1. So if these patients have refractory angina or instability, whichever of the two, you should take the patient to a cath lab immediately. Stat, right now, no question about it. And 2 would be, in this context, NSTEMI or unstable angina, which you initially stabilized, but the patient presents high risk for MACE, major adverse cardiac events, take this patient in an early fashion. Early catheterization is less than or equal to 24 hours. Okay, and in the context of STEMI, number one, OCA is out of hospital cardiac arrest plus return of spontaneous circulation plus an initial EKG with a STEMI. Take this patient immediately, because probably the substrate or the reason for this is will be found in the coronary angiography. 2. If the patient has STEMI and ischemic symptoms which have lasted less than or equal to 12 hours, take him or her immediately. 3. In this same patient with fibrinolytic contraindications, irrespective of time delay from the first medical contact. And 4. STEMI plus cardiogenic shock or acute heart failure, irrespective of myocardial infarction onset. All these patients I just mentioned with the green background means class 1, and the different grading for these indications. So coronary angiography indicated, no question about it, strong evidence. Now we're going on to class 2A evidence. Okay, same for this. On the left, yellow color is telling you that it is suggested. It is suggested and isn't written in stone, isn't such a strong indication as class 1, but it is suggested. Though then, in the patient with stable coronary artery disease, in which you have clinical and stress test findings which indicate a high probability of ischemic heart disease, it is suggested to take them. 2. Stable ischemic heart disease suspected in patient who cannot undergo a stress test or who has testing done with indeterminate findings, or with high likelihood of benefit from the treatment. 3. Patients with left ventricular ejection fraction less than or equal to 50% plus moderate risk in the non-invasive testing. 4. Inconclusive prognosis and information of the testing inconclusive prognosis in which testing is inconclusive, indeterminate or contraindicated. And 5, in the patient with angina plus left ventricular ejection fraction more than 50% with high risk findings in stress testing. Sorry, I'm going a little slow in this one because the background isn't helping me out with that yellow color. Remember that yellow is class 2A. Now, what about the context in ST and STEMI, or acute coronary syndrome? Acute coronary syndrome manifested by NSTEMI or unstable angina. What is the indication here? You would prefer, it is suggested, to take the patient early over delayed in initially stabilized high-risk patients. In patients with low-risk features, you can choose a delayed strategy. How can I differentiate high risk from low risk from medium risk? We'll see this in the next slides. Now, in the context of STEMI, 1, if the patient has ongoing ischemia, whether it be found clinically or electrically, between 12 and 24 hours. This is class 2A. Remember that class 1 was in the first STEMI in first 12 hours. That's class 1. If the patient has ongoing ischemia between 12 and 24 hours, take this patient to the cath lab, 2A. Now we're passing to recommendation 2B. This isn't recommended. This isn't suggested. This is may consider. Class 2B is may consider taking this patient to coronary angiography. What about the context of stable coronary artery disease? 1. Stress test is negative for coronary artery disease, but you as a clinician has a very high suspicion, clinical suspicion, that there is coronary artery disease and possible benefits of taking this patient to cath lab. What about in acute coronary syndrome manifested by NSTEMI or unstable angina? 1. If you initially stabilize the patient with high risk for MACE, it is recommended, you may consider an ischemia guided strategy. What is this? For example, this initially stabilized patient, you make an echo stress test, and if you see that there is inducible ischemia, you may consider taking this patient to the cath lab. Okay, if this patient, initially stabilized high risk patient. And 2, in this same patients, after consideration by the clinician and patient preference, taking into account these subjective decisions. And in the context of STEMI, there is no 2B recommendations. So, this is what determines if the stress test findings are low, intermediate, or high risk. It depends on the cardiac mortality. If it's less than 1%, it's low risk. 1 to 3% is intermediate risk, and greater than 3% is high risk. Patients with high risk pretest probability should go to angiography without a delay. Which are the patients with high pretest probability? Risk factors in general, you have patients that have acute coronary syndrome. These are patients which have high pretest possibility, and they should be taken to cath lab. Be it early or be it delayed, they should be taken to the cath lab. If you don't have high risk pretest probability and you fall into intermediate or low pretest, there is the scenario where you're gonna have to decide if this patient should be delayed or this patient should not go at all to the cath lab. There are some risk factors that support early invasive evaluation. This means less than 24 hours. For example, significant troponin increase, a diagnostic ST or T wave change, a Gray score more than 140. In the context of patients with diabetes mellitus, reduced LV function or fraction, here it states less than 40% based on most of the studies here, but you know that reduced LV is less than 50% in general. Early post-infarction angina, recent PCI, prior CABG, or intermediate to high Gray's risk score. So then you have the appropriate use criteria. This talks about if it is appropriate, if it may be appropriate, and rarely appropriate. Why is this important? Because angiographically normal or minimally diseased coronary arteries are found in 39% of patients undergoing elective procedures. So PCI in asymptomatic patients remains uncertain. This is why it's important to decide these criteria in order to diminish the rate of patients who should not be taken to cath lab, and be sure to take those patients who should be taken to cath lab. Remember that for each patient that is in the cath lab, there might be one patient that should be in the cath lab that cannot go to cath lab because there is another one in the cath lab at that present moment. So, which are the complications and contraindications? We'll see it on the next video in part 2.